A very good afternoon to everyone at PGES. I'm extremely disappointed to not be able to attend the meeting this time because of certain work commitments, which I was forced to quite literally perform. But at least I get to record this and send across my talk. Gaurav sir was right. I'm missing out on all the fun and the interaction between the colleagues and seniors. But I hope my luck is on my side next time. Without further ado, I begin with the task that I was given, which was to talk on ablative techniques in thyroid nodules. And we all know that in the current era, patients are preferring heat over surgery because minimally invasive thyroid ablative procedures have become very viable alternatives and have gained widespread acceptance as safe and effective procedures to reduce the size of the thyroid nodules and alleviate symptoms. The ablative techniques that are commonly being used these days are radiofrequency ablation, microwave ablation, laser ablation, and high intensity focused ultrasound. Each of these cause thermal ablation by heat generation within the thyroid nodule, causing coagulative necrosis, cell death, and thereby reduction in the size or disappearance of the nodule itself. There are certain other techniques which are based on chemicals like ethanol, which cause direct tissue death, thereby leading to decrease in the size of nodules. And furthermore, are cryoablation and irreversible electroporation techniques, which are based on freezing of the tissue, leading to cell death. However, cryoablation and irreversible electroporation are not very much in use, and we do not have a lot of literature on their utility in thyroid nodules. The most uh, frequently performed ones are radiofrequency ablation and microwave ablation. Coming to the indications of ablative procedures in thyroid nodules, we all know that TIRADS 1, 2, and 3 lesions or AFTNs in patients who are high risk candidates for surgery or radioactive iodine ablation can very easily be subjected to ablative techniques. Even in malignancy, patients who have papillary microthyroid carcinoma or recurrent PTC having less than 3 lesions measuring less than 2 centimeters in size have easily been ablated using these techniques. Also, indeterminate nodules with negative molecular tests are being subjected to ablation. Although we do not have a lot of evidence available currently, and the guidelines don't recommend them usually, but there are reports that are coming up that indeterminate nodules can also be subjected to ablative procedures provided their molecular tests are negative. So the contraindications, of course, are just the opposite. Indeterminate nodules with positive molecular tests, malignant thyroid nodules measuring more than 2 centimeters in size, and all those lesions which we are not able to visualize on ultrasound. The prerequisites that we need to keep in mind before we subject a patient to ablative procedures is, of course, a laryngoscopy and basal calcitonin as per the European Thyroid Association. Informed consent is extremely important in all patients because their expectations need to match our outcomes. And therefore, a proper template of informed consent with all the information in the patient's language should be provided to the patient. This procedure can be done under local, regional, or general anesthesia, and I think that's the best part about it. Coming to the procedure, the patient lies supine on the table with the generator on the side and a grounding pad attached to the thigh or the calf, and the surgeon uses the electrode under ultrasound guidance, inserts it into the thyroid trans-ischemically, as is seen in this picture, and starts the ablation of the thyroid nodule after doing a hydrodissection with lignocaine or saline. Now, the ablation has to be done from distal to proximal or posterior part of the nodule to the anterior part. The probe needs to go along all the axis of the nodules, and small ablative units are created by the active tip, which stays at a point for around 5 to 9 seconds and then moves proximally. This technique is called moving shot technique and in complete ablation of the tumor. A post-procedural checklist should be maintained for all the patients and they should be observed for 30 to 60 minutes, after which they can easily be discharged with certain discharge instructions. This is one of the thyroid nodule that I ablated recently, and you can actually see the nodule being very distinct here, and the tumescent has been given in the area around the nodule. After ablation, the margins have become indistinct, and small ablative units can be easily appreciated in this ultrasound. After the procedure, the patient needs to be followed up at 3 months, 3 to 6 months, and at 12 months. At each follow-up, we need to assess clinical, biochemical, and sonographic parameters, the most important one being sonographic one, because the volume reduction rate of the thyroid nodule is the one that is the indicator of the success of your procedure. Oh, nobody would have performed these procedures had there not been evidence for their outcomes. The outcome that we look for after a thyroid nodule ablative procedure is the volume reduction, symptom and cosmetic improvement, the rate of complications post-procedure, the nodule regrowth, and additional treatment or sessions required. In cases of papillary microthyroid carcinoma or recurrent thyroid carcinoma, the tumor disappearance, the local recurrence, and lymph node metastasis become very, very important outcome indicators. This table here shows the volume reduction rate of radiofrequency ablation, which is in the tune of 76 to 99% for various kinds of nodules. Similarly, microwave ablation also is associated with 85% plus volume reduction rate. Laser ablation and high-intensity focused ultrasound have a slightly decreased rates of volume reduction, but that is really not because of the procedure, but rather because of the fact that these procedures are performed in less number of patients and therefore we have less data. Zhu et al. Recently did a meta-analysis where he pooled the mean volume of reduction rate of all the thyroid ablative procedures during the 5-year follow-up period. And he found that at 6 months, 61.83% volume reduction was seen, which only increased to 81.43 at the end of 5 years, which is quite significant. Also, when compared with surgery, thermal ablation is not only associated with significantly decreased nodule volume, but it is also associated with lower postoperative complications in the form of hoarseness of voice or RNL injury and hypercalcemia, and also improved perioperative outcomes in the form of early discharge, early recovery, and also good quality of life. There was a preservation of thyroid function in 93% of patients undergoing thermal ablation as compared to 71% patients undergoing surgery, which is again a big thumbs up for ablative procedures. Even for tumor progression or recurrence-free survival, there was no difference between ablative procedures versus surgery, which gives a very good upper hand to thermal ablation as compared to surgery. Now, if you ask me which one of the thermal techniques is better than the other, then the evidence supports radiofrequency ablation as per the current guidelines, because it has the highest volume reduction rate at both 1 and 12 months among the 4 treatment modalities of RFA, microwave, laser, and HIFU. A cumulative ranking analysis was done for all the procedures that are done for thyroid nodules, and it was seen that at 12 months, the radiofrequency ablation had the highest VRR, which was sustained up to 36 months. So the RFA had slight advantage in symptom relief, and the microwave had a slight advantage in aesthetic outcomes. But in cases of papillary thyroid microcarcinoma or recurrent thyroid carcinoma, Lee et al. Reported that microwave ablation had the lowest recurrence probability But for minimizing the lymph node metastasis, radiofrequency ablation ranked the highest. So currently, radiofrequency ablation and microwave ablation are the bosses of thyroid ablation techniques. One may be better than the other in certain aspects, but overall, they are minimally invasive, they are safe and effective, they are comparable to surgery in well-selected patients, or even better at times. And all the evidence that we have till now is in their favor. So the take-home message that I would like to give here is that we should select our patients carefully, in whom we can perform these procedures safely and effectively. And I'm sure that this might very soon become the gold standard of management of thyroid nodules, provided we have a long-term follow-up. That is to be the long-term follow-up in our research. With that, I thank you.